name is Saowanee Ngamruengphong. I'd like to thank AWE for an opportunity to be part of this program. The topic of my talk is What's New in ESD. This is my disclosure. We are going to review recent articles on ESD that related to technical impact of ESD, and then recent studies on modified techniques of ESD. Start with the impact of ESD on management of Barrett's neoplasia. We know that EMR of Barrett visible lesions result in change in histologic diagnosis of Barrett's staging. In this prospective study of over 200 patients with Barrett visible neoplasia underwent ESD, the authors compare pre-ESD histology from biopsy and post-ESD final histologic diagnosis. They found that ESD resulted in change in pathologic diagnosis in more than half of the patients, and 68% of those were upstage, and over 50% of those patients have diagnosis upstage to invasive cancer. So endoscopic resection including ESD is a critical step in obtaining information of the lesion staging that will guide diagnosis, and without this step, we may be doing ablation on the lesion that should have been treated by endoscopic resection or surgery. This patient with Barrett's esophagus and a 15 mm nodular lesion, previous biopsy only showed intramucosal cancer, but the lesion appearance is suspicious for deep invasion. You can see the depressed area at the center of the lesion. We perform ESD for pathologic staging for this lesion, because en-bloc resection with ESD allow a more precise histologic assessment of the resected specimen compared to piecemeal resection. This is particularly important for the lesion we suspect submucosal invasion. We know that ESD is superior to EMR for complete resection, but there were limited data on impact of ESD on rate of local recurrent and rate of reintervention. In this study involving 243 Barrett with high-grade dysplasia or T1 cancer that underwent EMR or ESD, R0 resection is superior with ESD, 73% versus 56% in the EMR group. Recurrent disease is lower in the ESD group, 3.5% versus 31% in the EMR group. Much higher proportion of patients in the EMR group required repeat endoscopic resection procedure compared with the ESD group, 24% versus 3.5%. And recurrent or residual disease-free survival was significantly higher in the ESD group. So this study suggests that ESD results in more definitive treatment for early Barrett's neoplasia with significantly lower recurrent disease and less need for repeat endoscopic treatment than the EMR. What about data on clinical outcome of esophageal squamous cell carcinoma after ESD compared to EMR? Most studies on this topic came from Asia. In a multi-center study from France, 132 patients with superficial esophageal squamous cell carcinoma underwent either EMR or ESD were compared, and they found that cancer recurrence was significantly lower in the ESD group, 2.9% versus 23%. And there were no significant differences in rate of perforations between the two groups. In this graph, you can see that recurrent-free survival was also significantly superior in the ESD group. So the conclusion of this study showed that ESD reduced recurrence and prolonged disease-free survival, supporting the use of ESD in treating esophageal squamous cell cancer in the Western setting. Next study is on long-term clinical outcome after colorectal ESD. This is a multi-center study from Japan, including over 1,800 colorectal lesions. The mean lesion size was 30 mm. Most lesions were located in the right colon, and about 25% were located in the rectum. The 5-year disease-specific survival and overall survival was 99 and 93%. And for patients that their index ESD meet curative resection criteria, the 5-year intestinal preservation, meaning avoid colectomy, was 98%. And after multiple surveillance colonoscopy, local recurrent rate was only 0.5%, considerably lower than that after EMR. The result of this study further support the use of ESD as a standard treatment for large colorectal lesion in Japan. But can we apply this result in the US? In the large multi-center prospective study on ESD from North America, including over 400 colorectal ESD, En bloc resection was almost 90%, which is slightly lower than the reports from Japan. And local recurrence is also slightly higher at 2.7% in this study. Still, we need long-term outcome data of colorectal ESD in the US. As of now, the suggested indication of colorectal ESD in the US still limited to the lesion with suspected superficial submucosal invasive cancer, lesion with severe submucosal fibrosis, or lesion with positive vertical margins after EMR. In the West, selective use of ESD for colorectal lesions may be an optimal approach as opposed to universal ESD for all large colorectal lesions. The recent study from Australia compared outcome of selective resection strategy to the control group, which is universal EMR for all lesions. In the selective resection strategy group, they performed ESD for lesions with features suspicious for superficial submucosal invasive cancer, such as lesions with Kudo pit pattern type 5, non-granular lesions, or granular lesion with dominant nodule larger than 10 mm. The remaining lesions underwent EMR. Overall, they found submucosal invasive cancer in 12% of all lesions. There were more cancer resected by piecemeal EMR in the universal EMR group. More importantly, curative oncologic resection was higher in the selective resection group, 33% versus 5%. Selective use of ESD mitigates the risk of piecemeal resection of rectal cancer and improves oncologic outcomes. This study suggests that ESD should be the preferred option for the lesions with high-risk features for submucosal invasive cancer. Another use of ESD is in the patient with inflammatory bowel disease. This is a 45 mm dysplastic lesion in the rectum of patient with long-standing ulcerative colitis. This is a flat elevated lesion, no depletion. The margins are clearly defined. There's no active inflammation or ulcerations in the surrounding mucosa. The lesion is diffusely non-lifted after submucosal injection, and EMR is not possible to achieve en bloc resection. The biopsy of this lesion shows high-grade dysplasia, and en bloc resection is preferred to increase the chance of curative resection. So this lesion was removed en bloc by ESD. There was submucosal fibrosis and submucosal fat. Because of the narrow submucosal space, it is more difficult to dissect in the fat tissue. ESD for dysplastic lesion in chronic colitis is typically more challenging procedure than the ESD in the non-colitic patients. The pathology of this lesion shows high-grade dysplasia and R0 resection, therefore the patient can avoid surgery. There are not a lot of data on ESD for colonic dysplasia in IBD from the Western centers. In the recent multi-center US study, including 45 dysplastic lesions, median lesion size was 30 mm and submucosal fibrosis was noted in majority of lesions, 73%. Half of the lesion was in the rectum. En bloc resection rate was very high, 95%, but R0 resection was slightly lower than the previous report in non-colitic patients at 75%. Intraprocedural perforation was reported in 2% and all were treated by endoscopic closure, and local recurrence occurred in only 2.6%. In patients with IBD, the lesion margins are sometimes less clear, and that might explain the lower R0 resection in this series. But overall, ESD appears to be safe and effective for en bloc resection of this lesion, regardless of the size and the presence of submucosal fibrosis. Although rates of en bloc resection for colonic ESD is generally high, a significant proportion of patients have positive horizontal margin on the resected specimens. This could be due to unclear lesion margins, cautery artifact, or suboptimal specimen handling techniques. But because the perceived increased risk of local recurrence, we typically recommend intensive endoscopic follow-up. But what is the risk of local recurrence of these lesions? In this study, they look at rates of local recurrence for colorectal lesions treated by en bloc ESD. For non-invasive lesions, local recurrence of lesions with positive horizontal margin or HM1 is in fact low at 2% and not significantly different from that of lesions with negative horizontal margin with a local recurrence of 0.5%. But for T1 cancer, local recurrence of lesions with positive horizontal margins was high, 25%. Based on this data, it's somewhat reassuring that Local recurrence of non-invasive colorectal lesions treated by en bloc ESD with positive horizontal margins is still quite low, at about 2%. And these patients may not need intensive close endoscopic follow-up. 12 months after initial ESD might be justified. However, the same conclusion cannot be applied for T1 cancer. We're going to move on to recent data on techniques of ESD. Start with traction. Traction can facilitate ESD by improved visualization of submucosal layer, allow dissection to be more efficient and safer. There are several traction techniques that can be used during ESD, which can be categorized into internal or external traction. Most of these traction techniques utilize the readily available instrument or accessories in the endoscopy unit, such as clip with line or suture, or clips with rubber band. In the meta-analysis comparing traction-assisted ESD with conventional ESD, including over 2,000 lesions, they found that traction-assisted ESD is associated with lower procedure time, increased R0 resection, and decreased risk of perforations. Endoscopists who perform ESD should also learn several traction techniques, as it can get you out of trouble during the difficult ESD. Example of internal traction. This is a 25 mm granular LST nodular mixed type in the rectosigmoid colon. After mucosal incision and initial submucosal dissection, it was difficult to enter submucosal space. Therefore, we used clip with rubber band traction method. After circumferential mucosal incision was completed, we placed a clip attached with rubber band at the mucosal flap. Another clip capture the rubber band and place the clip at the opposite wall to provide traction. Now submucosa has better exposed. Now we have better visualization of the cutting plane, and we can continue submucosal dissection. We can adjust amount of traction by adjusting the amount of insufflation. You can see that dissection has become faster because the widely exposed submucosal plane. En bloc resections was achieved. ESD procedure time was 25 minutes. The advantage of internal traction using clip with rubber band technique is that we can apply traction anywhere in the GI tract without having to remove the endoscope from the patient. When encounter large lesions, we can still use this technique by applying traction at different areas of the lesion. Another commonly used modified ESD technique is pocket creation method. A unique feature of pocket creation method is performing submucosal dissection before circumferential mucosal incision by creating the pocket underneath the lesion. Because only a small mucosal incision is made at the beginning, this prevents leakage of injected solution, and within the pocket, we can adjust the approaching angle to the muscle layer to be more horizontal approach and decrease the effect of respiratory movement during the dissection. This is a 12 mm early gastric cancer that was resected by pocket creation method. In this view, the lesion is seen in the retroflex position in the fundus. With minimal insufflation, we are now able to visualize the proximal margin of the lesion in the forward viewing position. First, perform mucosal incision about 2 cm in length, approximately 1 cm proximal to the lesion. Using a cone-shaped distal attachment, allow easier access into the submucosal space within the pocket. Once the scope tip enters the submucosal space, perform submucosal dissection along the muscle plane. After completion of submucosal dissection underneath the lesion, opening the pocket or perform circumferential mucosal incision. Here, completion of ESD with en bloc specimen. In a meta-analysis of 8 studies involving over 1,500 lesions compared to conventional ESD, pocket creation method was associated with higher en bloc resection, higher R0 resection, increased dissection speed, and decreased risk of perforation. This technique facilitates high-quality, fast, and safe ESD. A new category of ESD knife is scissor-type knife. It is designed to grasp and cut the tissue being held within the blades, allowing a more controlled dissection and potentially may prevent unexpected muscle injury. This is a 5 cm laterally spreading tumor in the rectum resected by ESD. Steps of ESD using scissor-type knives is similar to tip cutting knife. This one knife can be used for the entire step of ESD, including incision, dissection, and coagulation. To perform dissection, grasp the tissue, pull and cut, and repeat the steps. You can see that the scope tip doesn't have to be moved left or right, different from how we perform ESD using tip cutting knife, which makes the ESD easier, particularly in the hands of trainees or when the scope maneuverability is poor. In a propensity score match study comparing the efficacy and safety of ESD using scissor-type knives versus needle-type knives for colonic ESD, including over 1,200 lesions with a mean lesion size of 31 mm, there were no differences in rate of en bloc and R0 resections between the two groups. However, adverse events including intraprocedural perforation and delayed bleeding were significantly lower with the use of scissor-type knife. However, dissection speed is slower with this knife. So the use of scissor-type knives improves safety of ESD with the trade-off of slower resection speed compared with the needle-type knives. In conclusion, more and more studies show the impact of ESD on long-term clinical outcomes, supporting the use of ESD as a primary treatment option for selected GI lesions. And several modified ESD techniques and devices improve safety and procedure efficiency, which will likely promote widespread use of ESD in the West.